number 3 in today's program, which is our legal panel. We've got two gentlemen here who really know the statutory and the legislative issues better than anyone in the country regarding direct primary care. So without any further ado, we'll get started and have Jay Keese talk to us about the legislative and policy landscape for DPC. Jay?
First of all, thank you very much for having us here, and thank you for the opportunity to talk to you a little bit about what's going on with direct primary care. I'm not going to spend a lot of time talking about what that is because that's essentially what this conference is, except to say that one of the great things we love about direct primary care is you know, every single one of you does it a little bit differently. And as I go through my remarks and talk a little bit about what's going on, I think it's important to understand that flexibility and that the beauty of direct primary care that allows me to walk into an office in Washington and say, if you've seen one direct primary care practice, you've seen one direct primary care practice. That's something that we want to keep and we want to grow and we want to nurture and is one of the more popular things about it. But it's really gotten a lot of traction, as you're probably aware. How many things do you think were in the Affordable Care Act, were also in the Cassidy-Graham repeal and replace bill, and are also likely to be in tax reform? How many provisions do you think were going to be in all of those things? Any guesses as to the one thing that was direct primary care? So we've had a lot of traction on our provision in the Primary Care Enhancement Act, largely due to the efforts of a lot of people in this room, a few of which I want to recognize. We have a steering committee at the Direct Primary Care Coalition, and if you're not a member, I encourage you to go on and join. What we ask for is a very simple, you know, we're asking for your first patient. Give us your first patient and allow us to do what we do well, which is to forward the policy goals of direct primary care. So I know there are some steering committee members here, my lawyer and fellow steering committee member Phil Eskew. Who else in the room? Julie Gunther? There she is, thank you. Jeff Gold? Anybody else? Am I missing Tom White? Okay. We're a small but mighty group. We've had 3 fly-ins in Washington, D.C. this year. We, on the first day of the new session of Congress, we introduced the first bipartisan health care bill, the Primary Care Enhancement Act, which would help clarify the HSA regulations and the tax code to make them compatible with direct primary care. We're working hand in glove with the new administration in CMS, and we're also working in states around the country to provide assistance, testimony, and in some cases even on-the-ground assistance in states that have passed DPC laws or are considering them. The state of play, you've seen Phil's mapper before, 700 practices strong in about 48 states plus DC. All over the country, we hear about new practices every day. I will tell you that the one inquiry that I get most from non-physicians in the Direct Primary Care Coalition is, how do I find a direct primary care doctor? So we've added some new things on our website to try to help facilitate that. But again, our definition of direct primary care encompasses people that are doing primary care for a flat monthly fee and in some cases with a per visit fee outside of fee-for-service billing. The median fee is about $70 per member per month. And we've been able to show through data from all over the country now savings of anywhere between, frankly, about 18 and 30% of the total cost of care. You know, a lot of you in this room are working individually with patients, so we're working with individuals, we're working with employers who want to engage you to help take care of their employees. We're even working in some cases with Medicare Advantage, Medicaid, and a new area of growth with state employees plans around the country. I think you've seen some of these numbers before, but you know, the obvious economic value for the system that's created through direct primary care, I don't really need to talk too much about in this room, but we've got some data that backs that up. We've got data that says the overall cost reductions for employers in the overall cost of care is about 20%, data running roughly, I think, 2013 through 2015 from Washington State. We have some new data coming out of Colorado with Nextera Healthcare, working with a company called Digital Globe, a new study that they did last year that actually led to Digital Globe expanding the Nextera services of care nationwide. They're doing it in Virginia and doing it right here in Florida as well now, showing a 25.4% reduction in the overall cost of claims and a significant reduced reduction in risk scores for these employers, leading them to re-engage with Nextera and continue doing direct primary care. We've got Iora Healthcare that's showing in 11 markets around the country, inpatient hospital admissions reduced by 37%. You do not see any delivery system reform, any ACO, any patient-centered medical home, any other reform that's being talked about in Washington right now that's showing these kinds of numbers. And it's gotten the attention of a lot of people. It certainly has the attention of the White House. It certainly has the attention of Medicare and CMS that's trying to figure out a way to crack this nut without ruining the secret sauce that's within it, and we'll talk about that in a little bit. So we're really focused on three key policy areas, and one is state laws, making sure that it's legal for you to do what you're doing in your states. We have worked to pass laws in 23 states, and we'll go over those in a few minutes, and Phil will is able to fill in a lot more detail about what those laws are. They're all a little different, but in essence what they say is direct primary care is in fact a medical service regulated normally by the boards of medicine and not the state insurance commissioner. So it's a medical service outside of state insurance regulation. We have significant issues, as you all know, with the tax code. As you're probably aware, the IRS doesn't necessarily consider what you're doing a qualified health expense. They might. It's unclear. If you're only doing primary care, then yes, it's a qualified health expense. If you're doing primary care and being paid in a monthly fee, well, that's a completely different story. So there is a provision in the law that actually says, and this is not the law around health plans, this is the law around HSAs, that if you have an HSA, it must be paired with a high deductible health plan, and you can't have a second health plan. Unfortunately, the way the statute is written, the IRS interprets anybody that aggregates services, medical services together, and is paid in a monthly fee or a periodic fee, is a health plan. So as long as the IRS considers you all a health plan, how many people here are doctors who consider themselves a health plan? Nobody? Not one? And I've actually not met the animal of a health plan that isn't an insurance plan, but the IRS doesn't even care that you're not insurance and you don't bear risk. What they care about is that you get in the way and the gap between this high deductible health plan and healthcare services that they actually intended you to purchase with your HSA fee for service one at a time with your HSA. So what this does is it invalidates your ability to fund the HSA. So it's a technical problem. Nobody really wants this to be there. The IRS doesn't want to be there. The IRS doesn't want to enforce this. The law needs to be clarified, and we've spent a lot of time with the IRS to try to convince them that they have the authority to clarify this through regulatory action or through simple guidance. Hey, we don't consider you all health plans anymore. That would be a really easy letter for them to publish on the facts on their website, and it would be done. They're not going to do it. So we have to pass a law, and we're working really hard on that. And the third and final thing that I think we're working on right now, I say I think because every single day there's something new, and yesterday's news about these short-term health plans might actually carry some new stuff with it. We're working very closely now with Seema Verma, the administrator of Medicare, and her team at CMS and the CMS Center for Innovation on a new pilot. And that pilot intends to and will test direct primary care being offered through Medicare and through Medicaid. We'll walk through a little bit about what that might look like, but it's in the planning stages. It'll be a Center for Innovation demonstration under the authority of CMMI and the Affordable Care Act. And so it's a brand new thing, and it's interesting and shows a lot of promise, but obviously comes with some risks too that we'll talk about. So again, to run through the states, 23 laws have been passed, 8 new laws last year, including a couple of revisions of laws that needed some upgrading. We've got a couple of states, Pennsylvania. I know there's a number of folks here from PA that have been working on the bill there. That bill just recently passed out of the House unanimously, or pretty close to it, right? The House committee. And now goes over to the Senate, where it'll have a slightly harder time. We, after 2 years of trying, passed a bill in Virginia this past year, and again, 6 other states that have passed new laws that define DPC as a health service outside of the state insurance regulation. We're fairly certain, matter of fact, we know of at least 2 or 3 states that are going to go at this next year, and the likelihood of coming back and doing some revisions at some point in the near future is good. So we'll continue to be really active trying to pass state laws to make sure that what you do isn't defined as insurance. Another area that is becoming increasingly popular, I know Massachusetts is just starting to look at this in a demonstration, not a demonstration, actually a full-blown program that's being rolled out in Massachusetts. But state employees unions and state employees plans as employers are just like other employers beginning to look at the value equation of bringing DPC into that. The largest such demonstration is happening in the state of New Jersey, where they passed a direct primary care medical home pilot a couple of years ago. That pilot began to roll out this year and is up to 800,000 state, municipal, local employees are eligible to get their direct primary care through, I think, at least 2 DPC offerings. One of our members, Our Health, based in Philadelphia, but offering practices in South Jersey, is deep into this program. So bringing that value equation to state employees and working with them on these DPC flat fee programs. The Primary Care Enhancement Act, this is the bill that was introduced on the federal level. I would ask that every single one of you take a look at this, and we can share these slides with you. Call your senators and your member of Congress and ask them to co-sponsor this bill. We've had a lot of history with this language. There's a ton of bipartisan support around that. I can't emphasize how rare it is in this session of Congress to introduce a bipartisan health care bill that is sponsored, in this case, by Senator Bill Cassidy. Who knows Bill Cassidy? Have we heard his name recently? Jimmy Kimmel sure does. And Maria Cantwell, probably one of the most liberal members of the Senate from Washington State. One of the things they agree on is that it's absolutely ridiculous that the IRS considers what you do a health plan, and they want to have this simple language that will clarify that DPC is not a health plan, and that what you all do is, in fact, a qualified health expense, and allow people, not only people to fund their HSAs and have a relationship with their direct primary care doctor, but also to take that money out of their HSA and spend it on your monthly fees. And we think that would be transformational in terms of employers looking at DPC practices as a great vehicle to reduce their expenses and improve health care. These provisions are in about a half a dozen other bills. There is also a piece of legislation that's coming together at the end of the year. You'll hear it referred to as extenders or Medicare Extenders. There's a number of programs that probably 535 members of Congress want to be reauthorized this year, including the CHIP program. So they're looking at a package that's coming together right now that'll be with CHIP and some of the extender programs for Medicare. And there are 3 provisions in that being considered as a part of that, including the Primary Care Enhancement Act. Hopefully we'll be able to move this across the threshold this year. But you know, things go incrementally in Washington, but we do need your help. The more co-sponsors we can get on this bill, we have about 20 in the House, particularly Democratic co-sponsors. We've got Earl Blumenauer from Oregon, Democrat from the Ways and Means Committee, and Eric Paulson from Minnesota are our sponsors of HR 365. There's other resources on dpcare.org, but the request is very simple. You know, tell the IRS that I'm not a health plan, and please co-sponsor HR 365 and S 1358, the Primary Care Enhancement Act. This is the most important thing leaving today that you can do to help us move forward with this policy. We will likely have another fly-in either before the end of the year or at the very beginning of the year, depending on what kind of action we see on this stopgap bill. But we're going to continue to push this, and it's got a lot of it's got a lot of traction. The White House has become very engaged on it. The White House and HHS have asked the Hill several times to consider this in whatever they have moving forward. So the new administration that looks at trying to look at ideas about market-based healthcare and moving forward in a system that recognizes the relationship between doctors and patients, this is a very important one. There is also a pending CMS primary care initiative. If you go to the CMS Innovation Center website, Medicare.gov/innovation, you will see that the administration now has a request for information from people out there about what are some programs that CMMI could take to go in a new direction. Basically what they're saying is they've tried ACOs, they've tried advanced primary care, they've tried CPC Plus, they've tried a dozen other demos. They're closing a lot of them down. The bundled payments initiatives are wrapping up. The comprehensive joint replacement programs are wrapping up. They want the next set of ideas, and they are dead set on having a direct primary care demonstration. So they're likely to test three, frankly, different models. A larger clinic model that I think, well, maybe that might fit for me, but I'm not a small doctor. But Seema Verma, who sponsored Healthy Indiana, is very interested in doing a small clinic model with a small doctor that would also be funded through a direct payment to the beneficiary. So CMS pays the Medicaid or Medicare beneficiary, the Medicaid, Medicare beneficiary pays the doctor. So it really puts the direct back into direct primary care in working with Medicare or Medicaid. So we want to make sure that that option is included in any pilot that they move forward. They're likely to test the other models where there might be some risk share, gain share involved, but making sure that this pilot includes testing existing practices where you already see Medicare and Medicaid patients and allowing Medicare and Medicaid to pay them to pay you is something that we think is very important. And dealing with the Medicare opt-out provision is also going to be very important as well, and they've signaled their willingness to address that issue by allowing opted-out physicians to participate in these programs and not requiring physicians to opt out to participate in a program like that. So that's sort of a quick overview of what we've been doing at camp for the last 6 months. We'll have time for some Q&A a little bit later, but dpcare.org, please come and visit us, and please join us in Washington next time we have a fly-in.